Welcome to Inspiring Heartfelt Conversations presented by In Autumn's Cocoon. This is a series of conversations on a range of end-of-life topics with noted professionals in the field. My name is Barbara Morningstar, and today's topic is Deathbed Visions and Dreams. I'm blessed to have Dr. Christopher Kerr as my guest. Dr. Kerr is the Chief Medical Officer and Chief Executive Officer of Hospice Palliative Care in Buffalo, New York, which includes a 20-bed inpatient unit, from my understanding. He's also a Canadian boy at heart. He was born in Toronto and raised in Canada before moving south, and he's from a lineage of physicians, the generations up to the fifth generation now. So I'd love to welcome you, Dr. Kerr. I'm so grateful to have you on today to discuss this very sensitive yet important topic.
I'm grateful for you providing this platform. Thank you.
Okay. We actually initially met because I have also written a book on the transcendent experiences of the dying titled Honoring the Mystery. And it's a compilation of stories from the bedside of the dying. So I have a passion and a heart for this conversation too. But to lead into the first question, I want to bring art into the conversation. Years ago, a spiritual teacher of mine who's been very influential, a younger person asked him, if you could speak to the true nature of art, what would that be? And he said, I think that the answer will surprise you in some ways, but he said, the true nature of art is to learn structure so that the Holy Spirit can flow through. And I remember sitting there thinking, structure. And then I was pulled back to an experience when I was 15 on a Mediterranean cruise with my high school friends and ended up in the Vatican. I'm not Roman Catholic, but I was in the Vatican, and I ended up in front of a beautiful Michelangelo piece called Pieta. And it's a sculpture of the Madonna and Christ. And standing in front of that piece, I had a transcendent experience I can't even explain. I mean, you look at Michelangelo's work and the marble is so finely carved, the intimacy, the intricacy of it. But beyond the form of Madonna and this image of her holding the dead body of Christ kind of limp in her arms, there was this something else that flowed through that piece of art and just grabbed me and held me in front of the piece of art, and I couldn't move. It was transcendent. And so I reflected back to that piece and how profound that was. And so I want to bring that image into medicine because we have the structural element in the discipline of medicine, the science, the detail, the research, but then you don't see it often. Then if you move beyond that into the art of medicine, there's a different flow to the other deeper elements of the human condition. So I want to go into a turning point for you as a doctor and physician coming from that disciplined scientific background. And I see it as a turning for you as an invitation into moving into the art of medicine beyond the discipline. When did that happen for you, especially around the subjective experiences of the dying?
Yeah, it's a great metaphor, and it's accurate. It was really pretty simple to describe. It was when there are this dyad to medicine. There is the art and there is the science, and the science has clearly overwhelmed its art as we become progressively more enamored with technology and what can be done in disease treatment. What happened to me is I was very interesting. I had this kind of parallel existence. I was a cardiology fellow, so I was spending my days in a cath lab, which is highly technical and interventional. And then I was moonlighting at a hospice, and I was at the bedside of people who were dying. And all that veneer of support, technically and team-wise is gone, and there are no tricks left. You can't deceive yourself by doing things, and you're just forced to be present. And that's when I think that's when I began. You automatically then have to attend to the patient as a person, not as a problem to solve. And when that happened, that's when they kind of gave back to me in terms of understanding where they were and what mattered to them and what they were experiencing. So it was really that. And then I think what happened is I had a natural discomfiture to the whole thing. I wasn't something that I sought spiritually, but it was the recognition that it was so inherently therapeutic what they were going through. That no matter what you thought of its validity or ideology, is that ultimately it mattered to them and deeply, and to their loved ones. So it couldn't be ignored. And that's really what started it. And then from there, what spurred the research is fascinating. It was actually out of a frustration in teaching residents, students, and fellows. And their response to me was, I said, these people are having these inner experiences, and they're powerful, and they're meaningful and comforting. And they would say, there's no evidence. As if we can't biopsy or image it or measure it, it therefore doesn't exist. And as an abstraction, it wasn't going to be accepted. So that's what spurred the research, was to make the case.
Well, and to bridge to that, I was invited to teach some physicians who wanted to do a year to specialize in palliative care, and I was introducing the concept of the mystery and the transcend of the dying. And I'd spoken about the caregiver prior to that, and they were open. As soon as I moved into the subjective, half the room was fine, but the other half, like yours, I could feel their body language tensing, like, where is she going to take us? And one of the doctors in the room, who was getting a bit defensive about it, he said, but I took a Hippocratic oath as a physician. And of course, the Hippocratic oath is, I will do no harm. So he said, how do you take me into this in a way that I can traverse it but not do any harm? If they're seeing somebody that tells them to go off and do something kind of crazy, how do I distinguish between a delirium and a hallucination and one of these transcendent experiences? And so this is where I'd like you to respond, because you have done beautiful work and have a recent medical journal article out with a chart of the distinction you've noticed between a delirium and the deathbed vision and dreams. So can you just explain what you've observed as the difference?
Yeah, I guess I'm not sure where the physician was coming from, except that if he was confusing these experiences for delirium, and delirium is something he's supposed to intervene upon, which is true if it's harmful. I guess that's it, but they're it's apples and oranges.
So let me clarify. Yeah. I did say to him, as a physician, there's no way we're not asking you to do your due diligence in every form, because there can be those challenging experiences. But then we moved into sort of opening to the observation of something unique that is occurring that we may not normally pay attention to.
Yeah. This gets frustrating in its absurdity. I'll be blunt as I can. So delirium is a thing, a very common end of life symptom that the majority of patients experience, particularly near death. What's really, really important to clarify is that our research is IRB university approved, first of all. So it requires consent. The consent is like signing a mortgage. It needs witness. We screen every patient. We actually have 8 published papers on the topic, and every protocol demands you can't take a confused person into a study. So these folks actually, there's a screen for delirium that we screen them before each and every interview. So that's one thing. So we medically rule that out. We also look at labs and meds and all those sorts of things. The other thing though is this is the most important point. People miss the vantage point. So when you're talking about these experiences, they're talking about the moments before death. when there are cognitive changes. We're talking about the days, weeks, months before death. Some of these people are driving. They're independently functioning. They're doing their taxes. So delirium really isn't the issue. So the vantage point of when we're talking about it becomes very, very important. The other thing is delirium is a clearly defined state of cognitive disorganization. So people are tangential. They have trouble maintaining focus. They're discombobulated. They disorientated to their surroundings. The biggest thing with delirium is the vast majority is what they call hyperactive delirium. So you're agitated, you're distressed. The themes are horrific. Someone's chasing you, there's a fire, et cetera, et cetera, et cetera. End of life experiences. First of all, delirious patients don't recall their experience in the same way. They don't come out of a delirium event. Boy, I remember I was in this, just doesn't happen. And in contrast, end of life experiences are highly organized. They're thematically organized and specific to the person. They have a basis in reality. They're easily recalled. The people have heightened acuity or understanding, not less. They're organized in their thoughts. And the biggest difference is how they're made feel. Where the delirious patients is the patient who gets tied down or medicated. These people are having a conversation like we're having a conversation and saying, I had this experience and this is what I experienced and this is how it made me feel. It's actually a heightened level of cognition, not a disorganized level of cognition. So you don't, they're not. It would be like taking somebody who went to church and felt a spiritual connection in prayer, and then they come in and telling you about it, and you felt the need to diagnose it. Yeah, it's just no, it's not delirium. But what I think doctors get stuck on, because they view dying as less of a continuum. So how doctors medicine views dying is we treat, and then all of a sudden the person's no longer treatable and they kind of fall off this cliff and they start the dying process. When most people are actually dying most of the time all along, we're doing things and hopefully we're extending life or improving quality of life, but they're actually in a dying process. And those changes aren't without consequences subjectively or internally. And that's what happens during this period. So it's not just that moment of gasping for air at the end. Does that help?
Absolutely. And richer in its dimensions that we sometimes miss is the physical body is becoming weaker, right? I mean, that's the beauty of your work, is highlighting the spiritual and emotional aliveness as the physical body is declining.
That's the great paradox. We actually published a study where we used dying as, and I think this is really interesting. We used dying as viewed as a negative experience, like a traumatic experience, like war. And there's actually measures for post-traumatic growth during the and the idea is that, while largely negative and hurtful experiences, there's also other changes that take place. And what we found is when we use this tool that's validated, we found people who are having these experiences actually showed positive gains. So they were gaining insight, they were learning, they were adapting right up into their last days of life. Right. And that highlights this paradox, because what we see is the physical decline, the organ failure, the obviously physical lessening, but spiritually, psychologically, there's something measurable going on that's going in the other direction. It says they're very, very much alive, psychologically and spiritually.
Right. Beautiful. So when you entered into the study, how do you enter into the conversation with the dying patient to make it safe for them to share? Because often these can be judged too, right? The sharing.
Yeah, you do too. And there's actually some data on that people are reluctant to share for fear of being ridiculed, particularly in a medical environment. I think what you do is you just normalize it and you give it permission or space to be acknowledged. So it's as simple as saying, look, there's a lot of changes, obviously, towards the end of life. A common one is that people have these kind of intense dreaming. They're in and out of sleep states. And they can feel very real. Da, 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 da. So you just I provide the framework. You're not trying to provide suggestibility, but you're just providing a framework for people to acknowledge it. The argument is that dying's lonely, and that this can make them more lonely if they're reluctant to express. So.
So you also in your studies, there's about 80% of the people that you said have had at least one of these experiences. What were the common themes or the content that you saw emerging in that group of people?
Yeah, it's actually closer to 90. It's about 80.
Oh, 90.
Yeah.
Okay.
And the real important piece to know there is that our incident rate is higher than what's probably being reported by 10-20%. The difference in our study, though, is that we ask people every day.
Mm-hmm.
So you just can't pick a moment in time, 4 weeks before death on a Tuesday and say, hey, so we asked it every day. Part of that is we wanted to see the changes over time as people got closer to death, what was happening. Thematically, we saw a lot. We actually did a separate paper on the themes. Overall, what we found was 85%, 83% were positive dreams. What we found is as people approach death, there's a dramatic increase in frequency of these experiences. And when we looked at the content, so patients had a menu of things they could choose from. The most common thing was this kind of idea of reunion with people who they loved and who they lost. When we measured comfort with theme, the most comforting dreams were of seeing the deceased. Mm-hmm. And those are the ones that increase the most before death. So there's this natural process where people are kind of soothed as they get closer to the end of their life. And the overarching theme is reconnecting with people who mattered most. And it's very specific to who. So there tends to be this editing process. So the people who loved you or nurtured you, didn't matter when in your life, it could be when you were young, those are the people who you see and experience. Other themes, travel or preparing to go is very common. The metaphor there is kind of obvious, but you see a lot of that. People, I mean, if you had to boil down the themes, it's kind of love and forgiveness. It's very positive themes. About 17% had distressing dreams, but those were some of the most transformational dreams. In that they addressed an issue. It could be, somebody had PTSD from war, for example, or had felt the failure as a parent because the child ended up in jail. But at the end, their parents come and forgive them. It's all that kind of thing. So those are actually some of the most meaningful.
So just even bridging, just sharing a profound experience. I've always been comfortable with this because of the tapestry of my life. And I think patients know when you're comfortable to ask a question. But my father is 98. And in your book, Death is But a Dream, you have a chapter where you honor longer term relationships with older couples, which I think is quite beautiful instead of that romantic ideal we often see in film. But he had a poignant experience I want to share, and why I love your research so much in validating. He died just about 6 months ago, but my mother had Alzheimer's for about 10 years, and he attended to her beautifully, and brought her flowers and had a deep bond of love. And after she died, he started to tell us that he was seeing her in the room. But there was a profound moment where he'd had another little stroke, and my older sister and I were flying back east to see her. And he woke up one morning from a lucid dream. And he said to the staff member that he had felt my mother crawl into bed with him, cuddle up with him, and he could feel her love in such a tactile, real way. He woke up so calm and moved, and he went to share it with the first staff person. And she said, "Don't be silly. She's dead. She died. Don't be silly." And so when my sister arrived, he was all upset because he couldn't tell, he was confused, going back and forth. This was real to me. And so she reassured him. We flew in a few days later. And when I first came into the room with my dad, he looked at me and he told my sister and I the experience. And it was beautiful, stunning. And he said, "Was it real? Was it real?" because he was so upset the nurse hadn't validated. That was causing him more harm. And we looked at him and said, Dad, what was that like for you? And he said, real. It was real. I could feel her. I could feel her love. I could feel her arms around me. And so we honored that and then said to him, then we celebrate that with you, Dad. And what a beautiful gift that she's come to visit you. I went to the staff after and started handing out my book saying, please don't do this to him again. So can you speak to how they talk about how real it feels and when validated, how that helps in
Yeah.
your research?
We actually measured degree of realism on a 0 to 10 scale, with 10 being the most real, and far and away the number ranked as 10. And in fact, one of the confusing things is that they feel virtual or lived. And the most common statement we hear is, no, this isn't like a normal dream. We have trouble with the whole nomenclature of dreams because we're told it's not a dream more than we are. I think there are maybe a few reasons for that. Is dying includes progressive sleep, and sleep architecture gets very disorganized. Whether these are lucid dreams, because a lot of people are claiming they're awake. When we ask them whether they were asleep or awake, and commonly they're awake, but it's not like you walk in and the person is having these experiences. So it has a feeling of being wakeful, being a participant, and it's actually not a memory. And yeah, there are tactile elements to this, so there are other senses involved. Somebody who lost their mother young age will smell the perfume, has all that sense of real to it. And that's why those videos in that documentary and the film are so important, because the patients themselves are emphatic that this was real. I think what it says, most importantly, is that it's felt. So the contrast between your nurse and your father is fascinating. So the nurse's standpoint is an objective sense. I don't see, therefore it isn't. Where to your dad, it was felt to the core, where it matters. So actually, it was more real than what she was trying to assess in a visual, perceptual sense. So yeah, no, that's exactly what it is.
Well, and I just want to bridge to that a bit too, because in your book and in some of the interviews that you've done, you make a clear distinction around what we qualify as dreams and end of life experiences. And you caution about coming into these end of life experiences with an analytical approach as opposed to being present to them.
Yeah.
So can you speak to that?
Yeah, I think this is very concerning, that if you just step back for a second and recognize that dying is a unique vantage point in life that is inherently going to change your perspective and your perception. And that from our position, we're not really in a position to judge. And it's almost as though we're applying a rubric or a context only we understand, and just not having enough reverence for the fact that the person in the bed might be having a unique experience that we just can't define. I think that's where we get really caught up, is that we're applying measures that we understand to a phenomenon that maybe isn't meant to be understood. It's a distinction between questions of the mind and questions of the brain. It's trying to measure love. It's all of those sort of abstractions. The fact that we can't prove or disprove doesn't disqualify the realism and the meaningfulness to the person experiencing it, right? And I think that's where medicine gets stuck, is that it deals with knowns. And I think, medicine has trouble with dying, period, let alone what we're talking about, which is the experience of dying. And the patient's perspective of dying. But yeah, I guess my problem with applying some of our nomenclature is that all we were trying to do, basically, or try to do in our research, is is that is give an audience to the words, to translate the words of the patients without assigning it, without editorializing it in terms of what it means to the afterlife. So if we're truly honoring the words, and we need to understand that that's what they're saying. No, 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 this isn't a dream. So I think dream, for example, is the only label we have. I just not sure it's an accurate label.
Well, and I'm thinking my husband died of cancer just over 12 years ago, and I'm thinking of two very different experiences. One, walking onto he had three primary cancers, and they were having trouble with his spine breaking down and pain management. And he was on a rotation of a medication that he became toxic on. And I walked onto the unit one day after an extreme nightmare he'd had that night, waking up, as you say, with kind of a delirium, a nightmare, a confusion, a fear. So he was on a staircase, and it disappeared in front of him, and he was afraid that if he let go, he was going to fall into this vast darkness. And as he woke up, he was buzzing for the nurses to come, and when they arrived, he wanted them to tie him into the bed rails so that he wouldn't fall. So they realized there was an issue with the toxicity in the medication. They changed it. But there was, even in the metaphor of that, when I walked in, he said, I had this dream. You can't talk me out. There's so much fear. You can't talk me out of it. And I could see the metaphor. So I just hopped into the bed and wrapped my love around him and cuddled him so he could go back to sleep. And they rotated the med, and it worked. The metaphor itself was reflective. So there was a depth to even that was interesting. But then later, like earlier on, he'd had a profound moment early in the morning at home where he'd woken up from a dream, more in that domain you're talking about. And he was just sitting there reflecting in the early morning. And I asked him if he was in pain, and he didn't say a word other than to say, it's not about power and struggle. It's not about power and struggle. And I said, it's about love. And he stopped and didn't say a word in the silence of that early morning light. And I could feel that my words were imposing on him. It was beyond language. And he just stopped in contemplation, trying to grasp or pull on something that he was in to communicate it. But I knew it was tough because it was beyond the literal. And then he said, it's the essence of love. It's the essence of love. We make it so difficult, but it's so simple. And then in that moment, you couldn't speak. It just went up and held him in the silence. And he in that moment was in one of those end of life experiences beyond the dream one earlier, that I had the gift, both of them, of being invited into. It was transcendent. It was so filled with love. It was tactile in the air of the room, but you can't analyze that moment. It was profound, right? So there's an interesting distinction in those two experiences that when you spoke of them in your writing, I understood the difference. It was profound.
Well, and that's just to your first piece of this was delirium, which is very classic, which is somebody gets deeper asleep, the dream intensity wakes them, and it wakes them suddenly and jarringly, and the thoughts and experiences are fearful. Often they feel they've got to get up and go, or they're going to fall. They'll help me, or they're reaching and grabbing for things in front of them. That's delirium. And it's very, very distressing. The other one is something else, which gave him this insight. And, and it becomes very important to know the distinction, because the risk is you sterilize people from their own end of life experiences and dying, and you really rob them of something that's very self-soothing and meaningful. Like it would have been a shame if they had medicated the latter, right?
Well, and let's get into the distressing dreams, because even in that, you tell a beautiful story of a man around war and a couple of others. I mean, even with my husband, even though there was that distressing dream, and he said to me, "You can't talk me out of this fear." I said, "I know, honey, but I can love you and be there for you." So I just crawled into bed, as I said, and I held him and cuddled him, and he fell asleep. And then I tried to step back hard at times when you're watching somebody going through that up and down with love. And he worked it through himself later. But can you give examples of people that when they've had distressing dreams and how you've worked with them and been present to that with
Yeah,
them?
I mean, people die as they live, and
Mm,
this isn't meant to be. End of life honors that, so it
mm,
doesn't deny the hard parts of having lived, and we all are injured for having lived, and oftentimes those injuries are central to our identity, or us being well, getting through them, and these come out at the end of life. And one of the things we did that was quite naive was we asked people to rank comforting, discomforting, and we assumed discomforting is negative, but discomforting actually was powerful.
mm,
And so some examples, for example, is the guy I talked about in the TED Talk, who was 67 years with PTSD, from being involved in the invasion of Normandy, and at the end of his life, he had two dreams. One in which he got to relive the day he got his discharge papers, which he said was the happiest day of his life, and the other was soldiers came to him on a beach and said that we're coming for you. And
mm,
so somehow he was relieved or unburdened by whatever survivor's guilt or whatever he had seen, and he was able to sleep after that. But what's fascinating is there's no drug therapy, no amount of talk therapy that could have got him to that point. It was always within him. There's just some very interesting. We have a man who lost his arm. He was poor in a blue collar family, and he lost his arm when he was 8. And there were a lot of kids, and the questions about how he was going to live, produce, be able to be on his own, that kind of thing. So central to his life was developmentally was growing up less abled or differently abled. And at the end of his life, he sees all of his coworkers and family walking by him, telling him he was better at his job than anybody else.
mm,
So it often focuses on that one thing that's core to our identity that may be painful or negative, but that also needs to be addressed. And sometimes that's forgiveness.
mm.
We see a lot of that, actually. In the video, I think, or in the documentary, you might have seen the story of Dwayne.
Do you want to elaborate on that a bit more? That's a beautiful story.
Multi-generational substance abuse. He'd been inner city African American here in Buffalo, and he had been on crack since the age of, I don't know, 13, 16. He actually had to come into our unit because his mother was using the drugs we were prescribing.
Mm,
He was in his 40s and he's had neck cancer. And what doesn't come out in the documentary is he actually murdered two people in self-defense. And he actually didn't serve time for them, but he was in jail more than he was out of jail in his life, mostly for buying and selling drugs. So he was just a jovial guy. He had a life he had to look forward. And he would joke about his dreams. And then on film, he breaks down and absolutely decompensates, because actually what he was having dreams that he was being stabbed at the site of his wounds in his neck by all the people he had hurt. But what that did was he woke up and he asked to reach out to a daughter that he had. And so we arranged the reunion, and it allowed him to say he was sorry and how much he loved her. And then he was able to sleep, and she stayed at his bedside. He died peacefully a few weeks later. But the experiences led to this reckoning, these dreams. So it didn't deny the realities of his life, but it helped him come to some sort of peace with it. For some of those dreams are honestly the most transformational.
I remember even coming into the room as after my husband had settled and saying to him, "Honey, you're one of the most fearless guys I've ever known." And I said, what happened? What happened with all of this? And he said, this time, facing his death, he said, normally I can touch it, I can see it, I can feel it, what's coming. This time I've had to learn to trust in a way I've never had to learn before. And like your beautiful man here that you're discussing, he'd lost a wife and a child to cancer earlier and not dealt with the deeper pain of those losses, which came forward. So I watched in the challenge of the pain, him being broken open and a healing and an emerging of coming to a place of loving that I hadn't seen to that depth in the 20 years that we'd been together, right? So I think it's beautiful when you're also seeing in your research those themes of love and forgiveness coming forward. And so let me ask you too. Some people say, well, are people seeing religious figures or in the context of a religious framework? What is happening in the research around that? Do you see that as consistent themes in the experiences, or
No, they're rare things. And we're not the first to report that. And at first that feels wrong, and you certainly don't want to be disrespectful to people's belief system. But they honor the tenets of faith, of love and forgiveness. And Carrie Egan, a Harvard divinity student, wrote a beautiful piece actually on this, about what people talk about when they died. And her argument is, to know God is to know love, and our first and last classroom is our family, and that's where we return to. And I think that's true. So I don't think they're incongruent. We certainly do hear references to the kind of symbols, those important symbols of religion, but not commonly.
So what about that small percentage? I see this in grief response too. Sometimes family or other people will hear about people having a dream or a unique experience. What about the ones who in your studies aren't having those experiences, and perhaps are aware of the study, coming alongside? How do you step in with that?
I don't know if we know anything about them, for a couple of reasons. Is a lot of the people fall out of our study for confusion reasons, or they become nonverbal or difficult to verbalize, have challenges finding their words. There's also this whole idea that, we're just taking a sample of time. So in a 24-hour period, we're popping by for 15, 20 minutes. So we just don't know, we have no idea really of what the people who are, or people who have unanticipated acute death. You do wonder, you take George Floyd, for example. What did he say as the cop was kneeling on him? He called out to his mother. Statements like, my life flashed before my eyes. In sudden event. I don't know. I don't know as we know. And I'm okay with that. Yeah.
Well, I think the reason I bring that up too is sometimes as we're opening this dialogue, I also want people to take a breath and give space to the dying person, so you're not hovering, waiting for an event you give space for it to organically be or not be, because sometimes there's a cocooning in and there isn't language as somebody's getting closer to departure, right?
And, it's and some people, it's deeply personal, and they'll acknowledge it, but they don't want to share it. One of the things we found, like with the book, was that everybody, and our research in general, is that everyone wants to participate, but there are people who are private and don't want to share. Some of it is oddly personal. So somebody who's had multiple spouses and they only love the second one, and that's the one they're seeing. Well, they don't want the children to know that, or whatever. It's life stuff. So I think some of it needs to be kept to that person privately. So there's
Hmm.
that aspect of it as well.
Well, and that is, some people are expressive and talkative in their grief, and others are more introspective and private, and
Yeah.
don't speak it as loudly. So that beautifully
Oh, I think it's
honors that.
fascinating, and it's less gentrified than you'd think. Um,
Hmm.
like in the documentary, Paul, for example, is just jovial about his dreams of his wife, and he can't
Hmm.
wait to tell his children every day about
Hmm.
his experience. And what you'll hear, like he said, that a lot of people say, I look forward to going to bed
Mm.
because of this reacquaintance with his wife.
Mm.
So that kind of comes out again and again. But and some, you're right. Some people, this is just they can't wait to tell people.
Hmm.
Yeah.
So very different that way. So let's touch on children. I remember meeting Elizabeth Kubler-Ross back in 1993 at a conference, and she's a bit of a cantankerous character. But she was talking a lot in her presentation about children and how open children are. And you speak so beautifully about some moments with children that you had touched you. You were feeling very protective of them. And then as you stepped into the experience with them, were quite moved at how they were facing their death. Can you talk about the different experience that you've had in working with children and how they've
Yeah.
approached?
I mean, the irony for me as a doctor is that I never wanted to do any pediatrics.
Mm.
That's all I do now. And we have a large pediatric program with about 120 kids in it a day. And those are the kids that I'm involved with. And one of my, I think, just visceral kind of responses was, how do you guide somebody through this? And, I was just very naive. And a couple of things you learn is they don't have reference points and they don't live with regret. So children don't say, I wish I had done this. They're just very much in the present. And one of the things that always shocks me is they'll have a very limited prognosis and how important it is they go to school the next day. Even though they're not going to be building on that knowledge in the future, there's no long-term gain, but what's in front of them is what they're living with them. And they have almost this assurance about what's happening, and they also self-inform in many cases through these experiences. So we've actually published a case series on several of these children, and the long and the short of it is they have these experiences in rich and vibrant ways, these end of life experiences. And where they may not have known of a person who died, they wouldn't know of an animal that had died. And on film, we have two of the children saying exactly the same thing. So when asked the significance, seeing that animals meant that they were loved and they weren't alone. So there's less distinction between animal and human. They also are creatively generate a world for themselves. So I think in the documentary, the one young girl talks about she's in a castle. Always dreamt of a castle with a pool. And when asked what was the castle, that was a safe place. And that is somebody actually who did have conversations with God the last day before she became nonverbal, which was the week she died. But what I learned was that they self-inform of where they're at and what their understanding is. They're reassured, they're comforted. If anything, their fears for the family they're leaving behind, which is remarkable. So it's concerned less for self. They do this with more assurance, if anything. Whatever lesion or they have or fear they have seems to get addressed. So in the book and the paper, we talked about this one young lady who was raised by a single mom, and who is she? What is she without her mother? And then she has a dream where she sees her mother's deceased friend, who she actually didn't know, in her mother's room playing with her drapes. So the message is the same. They're kind of they're secured, and they're loved.
Beautiful. So, and the wisdom and innocence of children, right? How to celebrate that as we come alongside of them and be open to what they can teach us as they're
Yeah.
facing their own death. Secondary impact. So the person who's dying having these unique experiences is comforting. But then what about the loved ones in that moment, in grief, and even staff, the effect on staff? Can you speak to that?
Yeah.
The
Um,
secondary ripple effect of these.
we've done, we published 2 papers on how this influences the bereaved, with surveys and interviews, I think, of over 750 people.
Mm.
And there's all sorts of scales we've used on impact of grief and processing, but the sum is that what's good for the patient is good for their loved one. And it turns out, not surprisingly, that how you see or imagine someone dying or leaving us absolutely influences your grief, your acceptance, your ability to connect, your ability to move on, all of those things. And I think what it comes down to is that if you're standing there and you've done this as you're talking about your husband, you're beyond obviously that they're physically comfortable, which is obvious and upfront, is where are they when their eyes are closed? Are they okay? Are they at peace? Are they comforting? And I think knowing what these end of life experiences do is where they don't deny death, but they also give it more meaning than what we would assume physically.
Mm.
And honestly, the best examples that I've seen are husband and wife that have been married for 60 years and they lost an infant. And the husband standing over his life partner and he sees her holding and referring to the baby that they lost.
Mm.
So nothing there denies that she's dying, it's what's happening, but it takes it from emptiness to meaning and love, and that she's put back together. And then there also connects them. So it's it completely recontextualizes loss, and it takes it from something empty that's something profoundly of worth.
Mm.
One of my favorite videos in the documentary is the one about the sauce, where her significant other, who had been taught his grandmother's sauce and didn't know what the last recipe was, woke up in the morning feeling like he had ate with her and felt full. He also learned what the last ingredient was. So the last 2 days of life, he made her go to the store and get and for 7 hours they made the sauce.
Oh.
So he wasn't becoming more isolated in his existence. He was actually ended up close to death, but more connected in his existence, and connected to the people who we love.
Beautiful.
Yeah.
So I have a couple of last reflections before we end. I was listening to a podcast recently by a hospice physician, and she was actually interviewing another doctor about the sort of buzz and curiosity about psychedelics helping, people at end of life when they're struggling and, with anxiety and potential breakthrough. And so there's research happening on that. But I thought there was quite an interesting moment in the middle of this discussion about the psychedelics and the possibility to help the dying with that. The physician who was interviewing said, "Oh, I had a patient once in hospice who had this amazing dream and had a breakthrough from the dream, paralleling, what happened with the research around that." And so there's a quote in your book when you're first coming up to present this as a research prospect, and I want to make sure I honor the way you've presented this. And you said that collecting information about the dying people's experience was a moral imperative for you to open this, to honor this. I'm adding my words to that, but can you speak to the commitment to this? Just even in that interview, I thought, well, okay, there's the buzz around the other, but look organically right in front of us. So can you speak to your commitment to open the dialogue on this?
I think that what we've done is we've sterilized what's inherently a human process.
Mm.
We've taken a highly medicalized approach, and people die in totality. They don't die by kidneys and lungs and parts. They and it's the ending of a life, not just a failure of an organ.
Mm.
And so I think there's a need to reclaim dying for what it is, which is more than a medical dilemma to solve. It's a human experience.
Mm.
The person in the bed doesn't give a damn anymore what his ejection fraction is or what his sodium level is. They care about what they're feeling and living, which it turns out is pretty remarkable stuff.
Mm.
And so I think that we got to kind of wrestle this away from the grasp of medicine, and put it in a different context, which also allows loved ones to come into it,
Mm-hmm.
in a different way, because that's what it is. It's more than medical futility. And there is a powerful motive to do this, because we've lost our way with this.
Mm-hmm.
We used to do this much better. It was a natural part of life. But medicine is a consumerism thing, and we're an ageist society that thinks you can do something about everything, including inevitable death. So we've deluded ourselves, and in doing so, we've harmed ourselves from appreciating an important part of life. So I guess that's where I fall. In terms of the psychedelic, I don't know a lot about it. I'm always leery. When I think it's fascinating, there's so much buzz around this when so much of it occurs naturally if you ask the right questions. So that's one. And two, there's not many examples in life where drugs mimic a psychological phenomena that rivals that which occurs authentically. But the evidence is pretty good, though, that they're doing some pretty remarkable things with it.
Well, and if you look back in history, they talk about a reference to those kind of things in tribal culture. But if you look back in ritual and tribal culture, dreams were a big part of vision quests. Dreams were a big part of gaining wisdom, insight, and healing in the history of our humanity, really, in the core cultural experiences and tribal experiences.
I'll tell you a funny story. So there's an Australian woman named Lynette Walworth, who's won 3 Emmys as a film producer. She's one of the world's authorities on the artificial stuff, VR, virtual reality. So she's working with Indigenous people in the Amazon and in the Australian outback, and completely unrelated to this dying business. But they keep bringing it up. And basically what they said, one of the leaders said, we're sad when somebody dies, but we know they're also okay because of these experiences they're having, which really is a way to tie them back ancestrally. They remain connected through these things. So she finds somebody references her to my book, and she calls me and she says, you do know that there's people on both ends of the earth here who actually have language for these experiences, and they're describing exactly what your research is describing. So yeah, it's always been there. There's literally nothing new we've done except put some structure to how it's measured, and some scales like post-traumatic growth or bereavement scales that gave it validity. And that was important because that was the only way it was going to be appreciated, really, in a larger sense.
Well, I think just giving it attention. I've been blessed. I'm a very lucid dreamer. I've kept dream journals for over 30 years. And after my husband died, I had so many unique experiences. I kept a separate journal just for him.
Yeah.
So I have a little bit of a lean to celebrate this, because organically for me, the wisdom that comes through them is profound. And when I've sat at the bedside in my hospice work to open that conversation, the rich engagement and sharing has been profound with the dying. They have taught me so much and enriched me, right?
Yeah, absolutely.
So I want to end, I always end with a personal heart question. And I sometimes the guests go, oh. Dr. Michael Kerr and I, beautiful palliative physician we both know, did a recent conversation on self-care, and he spoke of the wounded healer and how our own selves as human beings in the presence of others can have our own wounds that we bring. And interestingly enough, I said to you, the last 3 interviews, the one before you, this one, and the next one, are all palliative physicians who lost a parent. One in her 20s and you and the next young woman at earlier ages. So I want to bring you back to this poignant and touching moment with your dad, where you're 12 years old and you're in the room and he's nearing death and he's touching the buttons on your coat, sort of fixing them and saying that he's going to get a plane to take you to a fishing trip up in Canada, I think is what you said. But then coming into that is a priest who sort of moves you out of the room quickly, reducing that moment to a delirium and trying to protect you, moving you out. And then what your heart goes through as a young boy, and grief and protest after, but then luckily full circle. But I want to bring you back to that moment and change it a bit. So you're the young boy, the young 12-year-old boy with your dad and the buttons in this heartfelt connection. Instead of the priest coming in and qualifying it as a delirium, let's move him out. And I want you, as the mature physician, the wise man, the one more deepening in wisdom, who's been around these beautiful moments and coming into the room as the physician, seeing this young boy at 12 engaged in this, knowing what your heart knows now, what would you say to the young boy and how would you hold that moment?
Well, I think our obligations as doctors are to, our obligation as doctors is to find ways to bring people closer to the bedside, not farther from the bedside. So death of a loved one is an injury, and there's nothing good that comes out of it by disconnecting loved ones from that process. So you want to bring people to it, not from it. And for the dying person, again, it's lonely, and we need to make it less so. So again, it's this idea of bringing people together. I think it would have been the obligation as a physician in that scenario is to translate, is to say, your dad is okay. He's having these experiences, and this is what he's thinking of. His love for you, and he's comfortable, and bring it together rather than apart. Mm-hmm. I'm having trouble answering because I remember when you were as you were unfolding the question, I'm thinking it didn't matter at that time to me what the priest did or didn't do, because I knew intuitively that was my father, and his references were mine. We shared with him as we went on these trips every year. So there was nothing the priest was telling me or would have told me, honestly, that would have changed. That belonged in our relationship, and I knew that he was in a good spot. So
there's the wisdom of the child again.
Yeah, it certainly made me angry that I was being that I was being treated as a child, and that somebody was exercising control over me when they shouldn't have. Those are my honest feelings about it. But I think the clinical obligation is to explain things that might need explaining, to allow it to occur organically, to be present for that person so that they can be closer to the one they love, not farther from the one they love. I had an experience recently where I walk into the room and the daughter is sitting in the corner of the room stiff because her mom is having all these references and she's returned to her native Polish language. And it's disheartening. It's discombobulating as a child to see your parent different than you know them, and younger maybe than you know them, for example. Relativity is kind of lost. And what happened was I said, well, these are just really common. You should probably pay attention to what she's saying. It's okay. And on and on. And came back the next day, and the daughter's at the bedside with a notepad. And she's writing down everything her mother is saying because she's referring to the life that her daughter didn't know, which was in Poland. So she's hearing about her grandparents, the animals in her house, her friend. All of this early life is coming to surface, and she knew enough of the language that she could actually document it and become more familiar with her mother, not less, and more comforted rather than discomforted. So it's this idea, though. Literally, she was in the corner of the room, and the next day she was at the bedside.
Nice.
So that's what I'm referring to. That was my obligation, was not to dismiss, but to validate and explain where I could, so that there was really allowed her to get more proximate to it.
Mm-hmm. So how has your heart been changed by this work?
Well, I changed to the core just from being able to have this privilege as a physician. I'm inspired, honestly, by people, and particularly caregivers, who find courage and strength to do things they didn't know they could do, to stop their lives, to pick up and care and love the person. I think I'm left with the sense of a better story, that things that we think are lost aren't, and that the best parts of having lived remain and continue. So it doesn't feel, my perspective's broadened, my appreciation's broadened, my need to know all of this and define it isn't necessary. I just, again, have respect for it. You can't do this work hairless for 20 plus years and not just have some degree of reverence for the fact that it is. And that's it. And I think the other thing that's fascinating is that it pushes this on, because I really never really wanted to do a lot of this, like the book or the documentary. But what is really interesting to me is we did all this originally for a medical audience and didn't receive, it got published, but we never really heard it from anybody. But it continues to resonate with people around the world, like literally every day. We're overwhelmed with the responses to it. And what's fascinating is that there's this disconnect then between the people on the medical side who are giving the care and the recipients of the care, the patients and their loved ones, who this matters incredibly to. So, if you look on my TED Talks site, there's 3.2 million views, but that's actually not what's interesting. What's interesting is the over 5,000 responses. And what they're doing is they're responding by sharing their own stories, which is wonderful, because it's created a basis for which people could understand what they saw or experienced, and then the ability to share and talk about it is just tremendous. So that's what kind of propels. That's one of the things I think I've gotten from this, is that it started, I think, it helps to start a further conversation that's needed.
It's beautiful, absolutely needed. So thank you so much for coming. We will put on the screen later an image of your book, Death is But a Dream. It's a beautiful book, touching in on your research, but also the stories are so inspiring and insightful. And also, too, you have a PBS documentary coming out, which I've had the privilege of watching a few times. Can you tell us a little bit more about that and how people may access? But we'll also put links to both at the bottom of the YouTube page.
Sure. It's being shown through most of the United States and Southern Ontario. But one of the distributors is something called the World Channel, which puts it on digitally as well. So that will be sometime in April, and it's the same name as the book, which is Death is But a Dream. So it'll be available online as well.
Okay, great. Well, thank you so
Thank
much
you.
for coming on today, Chris. I really
Appreciate your
appreciate
time.
it. And
Thank you
and
for all
I'm
your work.
honor, yeah, honor and respect all the great work you're doing.
Thank you.
Okay.